Hi, everybody. Welcome to Medispec webinar. We have many people today joining our event. I would like to welcome our guests from all around the world. We have guests from Asia, from Europe, from Africa, I believe also from Latin America. I would like also to welcome the Medispec sales, marketing, services, and management teams. The topic of our today's webinar is Shockwave Therapy for Erectile Dysfunction, New Protocols and Techniques to Improve Results. We are very grateful to have Professor Lim with us. He will be leading the webinar. Professor Lim is a leading urologist from Singapore. He's both a professor with vast academic background as well as medical experience. He has been a long-time user of the ED1000 system and one of its pioneers. A few formalities before we start. We will allow time for questions at the end of the presentation. Please write the questions in English in the chat box area. It's normally on the right-hand side of the Zoom. This session is recorded and distributed together with the PowerPoint presentation. During the event, everyone is put on mute. This is to avoid background noise. Please stay tuned and follow our posts as we will be announcing our next webinar very soon. So without taking too much time of Professor Lim's presentation, please welcome Professor Lim. Professor Lim, you may start. Thank you.
Welcome. Now, my brief this afternoon is to introduce to the audience some new techniques we have been using to improve our results with shockwave therapy. Now, everybody knows how shockwave is being done. You not only can use it today for erectile dysfunction. As you can see on the right-hand bottom corner, there is a curvature due to Peyronie's disease. We also use it for maladie de la Peyronie nowadays too. Now, in all those studies where low-intensity shockwave was used for the treatment of ED, we have seen no reported adverse events. So this is a very safe technique that all physicians would be very comfortable to use. Now, the machine that I have been using for quite a number of years now is the ED1000, which is a superb machine. You can either have the full console on my left lower corner, or in the center, there is a portable version if you don't have space in your clinic or treatment area. Now, the basis of how this technology works is that it causes angiogenesis. As you can see that there's a blood vessel, and you can see from the endothelial lining, it seems to break off and form new blood vessels. And that's how this technology gives increased blood supply to the penile organ. Now, what does the shockwave effect cause? The shockwave that we generate causes shear stress and it causes cavitation. These are mechanical responses. And it leads to physiological reactions in the tissue in which three phenomena can be seen to happen. The first phenomenon is the stimulation of endothelial nitric oxide synthase, giving rise to increased nitric oxide in the tissue. The second is the release of endothelial growth factors, in particular VEGF. And the third is the production of proliferating cell nuclear antigen. And this three phenomena produces a clinical response which can be seen in the short term and in the long term. In the short term, what you see immediately would be vasodilatation, causing increased local perfusion. in the longer term, what happens is that you get angiogenesis, which leads to neovascularization, and therefore you get preservation of the good effects of the technology, giving rise to renewed erectile functionality. Now, nitric oxide, as I mentioned earlier, using the mechanism I showed on the left, is non-enzymatically formed by the shock wave. The technology of the shock wave enhances the expression of VEGF and its receptor FLT-1. And we have done studies to show that neovascularization is confirmed by the angiogenetic markers, which includes VEGF and eNOS expression and endothelial cell proliferation, which is determined by PCNA expression. Now, if you were to do CDU studies, you see improved peak systolic volume and resistive index. But because microvascularity rather than cavernous artery changes is responsible for the improved erectile function. Now, the mean penile circumference change.
Though I am taking that kickboxing class.
Professor Lim, you are on mute. We cannot hear you.
Okay, all right. Now, this is the literature which shows the proof of where the effects can be demonstrated. So the shear stress, the nitric oxide synthesis, the VEGF and FLT1 up regulation studies, the endothelial progenitor studies recruitment, the anti-inflammatory action of shock wave, neovascularization, local perfusion enhancement, and visual dilatation. These are all the authors that demonstrated it. So you can get all this information from the organizers if you wish to have it. Now this is not moving. Why is my this is not moving? Okay. Now let's go to clinical studies and data. Now the first clinical study on low intensity shockwave for treatment of ED was created by Professor Vardi. This is a famous Israeli doctor who has put this technology on the world map. Now what he did in this first study was to study how it improves erectile function in a 6-month follow-up study he conducted. Now, these are the parameters he evaluated. Now, if you look at these results, the baseline results and the results at 1 month at follow-up, if you were to shock the forearm, the baseline flow and the maximal flow don't change very much after a shock wave. The AUC also doesn't change very much. But when you shock the penis, the baseline flow, notice that it increases. At the baseline, it was 7.2, 4.6, but in 1 month, it was 17.7 and 10.3 respectively. And the maximum flow rates increased from 12.03 to 28.4 at the 1 month follow-up. But if you compare it to forearm, you notice that the numbers do not change much at all. Now, what about erectile function parameters? Again, at baseline and at 1 month follow-up, notice that IIEF ED domain, IIEF total, QEQ score, rigid score, and shear Q scores, they all improve after 1 month. And it's very dramatic. The numbers here show the improvement to be very significant as you look at the p-value on my extreme right. Now, Apple last year did an update of all these series in the world. And he, in particular, showed this demographic of the successful group in his best series of 72 patients here, where you can see that the shockwave technology improved ED 23% mild, 44% moderate, and 33% in the severe groups. And and for those who are responders to PDE5 inhibitors, 77%. And in diabetics here, you can see 32%. And his follow-up was very, 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 very detailed at first month and in the third month in the office, then at the 6th, 12 months, 18th month, and 25th month by a phone interview. So it's very, very thorough. So this study highlighted one important fact in the results. This was what everybody was asking. How long does the low intensity shockwave therapy effect last? Is it durable or not? So in this 2-year follow-up of this 72 patients done in this series, and they were considered successful at the first month of follow-up, and they were followed for 2 years, this is what we saw. Now you notice that the fall-off is marginally small. So even at 2 years, you can see that more than 50%, about 60%, nearly 60%, maintain the good results without any problem. Now, what about type 2 diabetes? Now, this whole group, led by luminaries like Francois Giuliano and so forth, they did a study on how it affects diabetes, type 2 diabetes. And they use an animal model using rats. And as you can see, they had a protocol, 2 sessions per week for 3 weeks, repeated after a 3-week interval. And they had even a washout period of 4 weeks before and so forth. And they found that it works very well in anesthetized, in rats that were diabetic. Now, I have a former trainee of mine who became quite a big user of ESWT in India. He is Dr. S. Vasan. Now, he did a very innovative study which we could not do in our country, but in India you can do it. Now, he did two arms. He created his patients in 2 arms. One arm, he shocked the penis, as like all of us are doing. In the other arm, when he's shocking the penis, inside the shocking head, he actually put a metal plate preventing the shock waves to reach the penile shaft. So to all intents and purposes, the patient's thing is exactly the same. But the second group actually, no shock waves reach the penis during the shocking. So it's a controlled trial. A trial actually. It's really a superb controlled trial. Now he used a 12-session protocol with an in-between 3-week rest period, and you can see that he had very good results in those that were treated properly, but in the sham group, it was very poor results. And this is the paper he published of these results in the Canadian Journal of Urology. Now, my good friend, Professor Irwin Goldstein, the famous erectile dysfunction guru from USA, happened to be coming for a lecture in Singapore. And in this lecture, he was told us that he was instructed by the FDA to test out shockwave therapy in the USA. And amongst other things he did, he confirmed the efficacy of shockwave therapy in treating erectile dysfunction. But in addition, he found that from lab tests that ESWT works by activating stem cells in the cavernosal tissue. And I was doing the same thing actually. I was actually using PRP, which is a stem cell activator, plasma, platelet-rich plasma. I was using it injected into the penis, and it had the same effect as stem cells injected into the penis. Now, from here, we concluded that ESWT can be used for arteriogenic erectile dysfunction. And we use a grading of the arteriogenic disease to predict the extent of response to the shockwave. If the disease is milder and the patient is younger, we note a better response. But in those who are older with more severe arterial disease, the response is weaker. I mean, as logically, we can expect this. Now, what about patients who are on PDE5 inhibitors? For these patients, post-treatment, we found that we could take off the use of PDE5 or reduce the dose of oral medication, and they can get a good erectile response. Now, ESWT during the treatment actually has an additional psychological effect of building confidence in the patient. Now, I have a lot of patients in my clinic, and I have got patients with proximal vascular occlusion. I have a vascular surgeon attached to my ED center, and we detect a lot of people with proximal vessel disease in the aortoiliac region. If there's vascular occlusion, unfortunately, we saw very poor or no response. Now, these are the important facts you need to know before you embark on ESWT recommendation. So we think that there's a possible role in modifying the primary pathology. If we can do preventative medicine, or we can give medication or whatever that can slow the progression of disease, we can improve the therapeutic effects of our shockwave. So I felt that because of all this, further studies were needed on how to optimize the result of ESWT. So I toyed with ideas of concomitant use of PDE5 inhibitors during ESWT or immediately after ESWT. I toyed with the idea of adjuvant use of stem cells or growth factors, and I will show you results of what I've been using and getting better results shortly. Now, let me first tell you about my initial study of ESWT over a period of 2.5 years in Gleneagles Hospital, Singapore. Now, you will note here that I had 240 patients recruited. I had 19 patients with chronic pelvic pain syndrome and 13 patients with Peyronie's disease. Now, if you look at the ED category, we could improve patients to erectile hardness score of 4 in 35% of the patients. We improve it to erectile hardness score of 3 in 40% of patients. Improving those to EHS2 only was 4%, and those who can improve only to EHS score 1 was 8%. So for my evaluation, all those who fell within erection hardness score of 1 and 2, I considered failures. It's very rigid criteria I use. They are actually improvement, but I consider them failures. And only if you improve to EHS 3 or 4, I consider success. And based on this stringent criteria, I had a success rate of 72%. Now, what about Peyronie's disease? Now, as you can see here, that in this small series, of which some of them I added adjunctive procedures like stem cell injection, verapamil injection, or penile traction therapy. But in general, the successful rate was 76%. And in particular, the plug became very much softer. And to the satisfaction of the patient, the patients were happy with the degree of softening of the plug. But I want to caution you about something, and that is, do not expect the plug to disappear. It does not disappear. It becomes pliable, softer, and more acceptable, and less painful or no pain. That's what it does. So if your patient has got high expectations, you have to caution them what to expect before you treat them with Peyronies for the Peyronie disease category. Now, what about chronic pelvic pain syndrome? Now, I treated patients with interstitial cystitis and patients with chronic prostatitis presenting with pain. The chronic prostatitis patients improved 86%, and the interstitial cystitis patients improved 80%. Very good figures, actually. So this is a modality par excellence for painful disease states. And it is to be expected, as you well know, shockwave therapy was used to treat orthopedic painful conditions. And this is just a repeat of the good results, but in soft tissues instead. Now let me show you my success rates for treatment for erectile dysfunction. Now, out of these 215 patients, out of 242, they all had improvement, as you can see. And the majority of the patients happened to be between 50 to 70 years of age. And this group fared the best. So I concluded that those who were in the younger age group who did not fare well must have other more severe concomitant disorders that will impact on a poorer outcome. And indeed, I think these are the reasons why they didn't do well. They could have hypogonadism, they could have diabetes, they could have high cholesterol and associated atherosclerosis or hypertension and so forth. And that's why the younger group did not do well. In the older group, the age factor was a big determinant of results. And of course, if they have severe comorbidities like proximal vessel disease and so forth, and other comorbidities of the elderly, then it will impact on the good results. So let's look at the failures. These are the failures, and it doesn't tell us very much, as you can see. But so I have to study what could be the comorbidities that impact on the failures. So in the next few slides, we'll demonstrate this. Now look at the patients who had diabetes compared to those who had no diabetes. Notice the yellow. The yellow bar means no diabetes. Those who had no diabetes fared very well, majority reaching EHS 3 or 4. And you can see the higher failure rate here of 54% belong to the group with diabetes. Although those with diabetes can respond, but they don't do so well. Now, what about those with ischemic heart disease? Similarly, those with no ischemic heart disease in the yellow bar had better results than those who had ischemic heart disease. Now, what about those with hypertension? Now, notice that those with hypertension, as long as you correct the hypertension before you treat, the results are not so dramatically different. You can get reasonable results provided you correct the hypertension before you treat the patient. Although there is some difference, but not phenomenally devastating changes noted in the two categories. But what was surprising to me was that people with high lipids in the blood fared badly compared to those with normal lipid levels, which could be the reason why why the arteries could be affected. And I think this is connected with the vasculature. Now, what about people with hypogonadism compared to those who are normal in their serum testosterone? So what we did was we shocked a group of patients where no testosterone replacement was given to those with hypogonadism. And in another group, we treated them, brought the low testosterone to a normal level before we did the shockwave. And notice here that if you treat the patients first, you bring the testosterone back to normal, the results are not bad. In fact, in those who had very good results, they overshot those who were actually not given the testosterone. You can see. So it's good practice to do a evaluation of testosterone levels and bring it back to normal before you treat them if you want better results. Now, again, if you look at age, notice that advanced age is a indicator for poorer results. You know, the older they are, the worse they can be expected to come out of this modality, and which is not surprising. Now, there was another thing which I toyed with, which is the use of assistance with PDE5 inhibitor levels in the tissues during shockwave therapy and following that. So I gave a group without adjunctive use of a long-acting PDE5 inhibitor, which was Cialis. Cialis is very good because it's long-acting. And I gave a group with the Cialis, and you notice that those who were given the PDE5 inhibitor responded much better to the shockwave therapy. Now, what about people who were using PDE5 inhibitors before the shockwave? Now, there was a group who had PDE5 inhibitor use before they had failure and then come requesting for shockwave. Now, there was another group who were PDE5 naive and then had ED and then came to us for ESWT. Now, look at those who were using PDE5 inhibitor previously, and then they noticed that the erection was getting bad, and now they requested shockwave, and that group in particular did better with shockwave than the group that had that were naive to PDE5 utilization before coming for the treatment. Now, this is Graham Jackson's series from Guy's and St. Thomas's Hospital. And from his cohort of patients, he found that the vascular disease constituted 30%, diabetes 40%, which gave a grand total of 70% of ED being due to diabetes and vascular disease. In other words, this group of people are in the majority, diabetes and vascular disease. And this is the very group that will respond to shockwave therapy. So shockwave is a good first line therapy for the majority of ED patients. This is the lesson to learn from this slide. Now let's look at treatment techniques and protocols, the main gist of this talk. Now, the standard way we treat patients is to use the three main areas: distal shaft, mid shaft, proximal shaft, and the right and left crus areas. So we need to shock these 5 areas. That's the usual place. And this is the graphic a pictorial representation of the areas you apply the shockwave. Now, what are protocols? The standard protocol that was used was 2 shocks in the first week, 2 sessions in the second week, and the last 2 sessions in the third week, followed by a 3-week period of a rest period. And then, if need be, for people who are on the 12-week protocol, you can carry on another 3 weeks of therapy. Now, my series, they all only had the 3-week therapy. There is 6 sessions. Now, there is a case to move on to a 12-week therapy, a 12-session therapy. Now, I will explain shortly. Now, you see, I use the word optional. Now, this optional group of another 3 weeks of therapy is best reserved for the failures after the 3-week therapy. If the people fail after 3 weeks of therapy, after you review them after the rest period, you can counsel them to go for another session with 6 sessions of therapy, bringing the total shockwave to 12 sessions. When you do this, you get another 33% or 1/3 of patients responding. Now, I have experimented with everyday therapy, 6 sessions continuously. And in particular, I had to do this because we have a lot of international patients who flew in. I even had an international patient flying in from Amsterdam. And after 6 days, he wanted to go back.
Está enseñando otros tipos de tratamiento, de protocolos.
So you have to quickly do it and get them back on the plane to their own country. So the continuous daily therapy is one protocol. Then I had another protocol, every other day therapy, the blue line, the blue bars, every other day. 1 day do, 1 day rest, 1 day do, 1 day rest. And then you have this therapy here where you get twice a week for 3 weeks. And then we had another group where we treated 3 times a week, every week for 2 weeks. And we found that we had almost the same results, whether you do it using any of these protocols. So basically, I now choose the protocol based on the needs of the patient. Now, what about the use of ESWT machine? Will a different machine give you a different result? Now, this elegant study was done by our good friends from Greece. Now, as you can see here, he used the Medispec machine using the 6-week protocol and the 12-week protocol. And then he used the Dornier German machine, again using protocol A, B, and C, as you can see here. In other words, 6 sessions, 12 sessions, or 18 sessions. And as you can see from this chart that the Medispec series used a 9,000 shock, total 9,000 shock protocol or 18,000 shock protocol. The Dornier had to use a 30,000 shock protocol, 60,000 shock protocol, or 90,000 shock protocol. And the success rates here, you notice that they were about the same, but the Dornier had to use many more shocks to get the good results. And the LI-EF change, you notice there again that in the Medispec series, compared to the Dornier series, that generally, if you take the average, the Medispec series produced a better LI-EF change compared to the Dornier series, unless you use a very high number of shocks for the Dornier, then you get back almost equivalent results compared to the Medispec series. Now, basically, this exercise of our Greek investigator here is to check for the efficacy, the efficiency of these machines. Now, the efficiency is defined by the number of shocks you need to give to get the same desired result. So as you can see here that the efficacy status assigned to the Dornier machines here is very low compared to the Medispec machines. You have to use so much more power, so much more shocks in order to get the same or lower end results. I mean, so it's therefore it had a low efficacy. If you want to get the same results, yes, you can, but you have to shoot more shocks, you see. So in other words, from an efficacy point of view, the German machine fared less well. Now, the other burning question which I always get bombarded with when I'm doing teaching on this subject is that, are there any contraindications to ESWT? Everybody asks this. Well, I say that they are, well, relative contraindication, they are absolute contraindications. Well, now, patients that do not have any erectile response at all, I would say it's almost absolute, it's a waste of time. If the patient comes to you without any vaginal penetration capability for years and years already, it's a very strong contraindication, because you better get the act right. Why they have never had any vaginal penetration for years and years. The disease could be an endpoint disease. So you better check this out before you offer the technology. Now, this technology is not for pure neurogenic patients. So if a patient is pure neurogenic, I would say it's absolute contraindication. Now, if the patient cannot respond either to a PDE5 inhibitor at all, zero, or he cannot respond at all to prostaglandin injection, I mean, these are hardcore patients already. The vasculogenic response that is usually created by a vasoactive substance injected cannot produce anything. What are you going likely to do with the injection, with the shockwave therapy? So these are very strong contraindications. And then now the patient, if he's totally non-compliant to recurrent sessions, I mean, it's a waste of time doing it. You cannot just do one session or two sessions and then he disappears off and then he doesn't complete the whole therapy program. I mean, these are patients you would like to advise to reconsider going for shockwave therapy. Now, the other burning question I'm always bombarded with is the doctors like to ask me, can an additional session of shockwave therapy improve the results for a group of patients that failed or only had partial response to the first series of therapy? Now, let us show you these results that have been published. Now, 33.3% had an improvement of more than 5 points when you go for a second round. You're going to recruit another 33% successes if you go for a second round. You have to counsel the patient, you're not going to get 100% success if I give you another session of it, another six sessions. But I will likely get you success to the tune of 33.3%. All right. So if it's comfortable with this success rate, then you start the second 6-session therapy. Now, what are the expectations? Now, if a patient had PDE5, which works for him before, and later on did not work, this majority of this group are expected to be able to perform without PDE5 inhibitors. All right? And PDE5 non-responders who previously responded when subjected to ESWT can be expected to become responders. So this is the counseling you have to give the patients. Now look at this series here that I referred to. Non-responders, You see, change by 5 points or more once you restart the second session. Now, the other question that I've always asked is that there are many patients undergoing radical prostatectomy today. And after prostatectomy, for cancer, they always get, quite often, not always, but quite often, majority of them get some degree of erectile dysfunction. Now, I've done it on patients with this background, and I want to quote for you Professor Gundeville's series here, 24 treatments in patients that have undergone radical prostatectomy at least 12 months prior to the ED1000 treatment. He had 3 out of 4 success in improving the IIEF, and those with concomitant use of PDE5 inhibitors, and no side effects were registered. So in other words, this is a godsend for those who have undergone cancer therapy. So if the patients have this problem, my own experience is to quickly start them. I would not wait 1 year. I got to tell Professor Gwendeville and Appel that I would not wait 1 year. Although the series they did it in people who waited 1 year. If they had erectile dysfunction, I will quickly, after the radical prostatectomy, start them on a low-dose chronic administration of PDE5 inhibitor. And if the ED is not recovered quickly, then I will ask them to initiate shockwave therapy very quickly. Now let's look at other indications for shockwave: Peyronie's disease and chronic pelvic pain syndrome. Now, I think most of you know the protocol for chronic pelvic pain syndrome: 300 shocks per location, and giving a total of 2,400 shocks per treatment. 8 locations are selected, with 2 over the penile crus or crura and 6 over the prostate. And you have to give 6 sessions, totaling 14,400 shocks per patient over the 6 sessions. And you give it twice a week here, and finishing in 3 weeks' time. Now, these are my own results in 19 patients. As you can see, I had excellent results in 3, good results in 5, fair results in 5, and failed in 2 patients, giving me a success rate of 86% for chronic prostatitis and 80% for interstitial cystitis. Now, what about Peyronie's disease? Now, before you treat with shockwave, make sure there's no local infection, clear any active sexually transmitted disease, make sure there's no malignancy at the area to be treated, and apply the treatment once a week for 6 weeks, total of 6 weeks. Each treatment session will be 3,000 shocks, and the whole treatment course will end with 18,000 shocks. Now, the area where you shoot the shock waves, you should do it by dividing the fibrotic plug into 3 sections and shooting it, dividing the total shocks into the 3 sections as illustrated in the bottom cartoon. Apply 1,000 shocks for each sector of the fibrotic plug, using a generous application of ultrasound gel. Now, this is my own success rate I report on my 13 cases for Peyronie's disease. And I had a 76% success rate, which means I get a soft, more compliant plug and no pain. If it's a painful Peyronie's disease, excellent modality to use. If you want a softer plug and a slightly improved contracture angle, yes, but you do not get excellent change in the contracture angle. You have to caution the patient beforehand. The angulation changes minimally, but the plug is softer, the erection is improved, and the pain disappears, but you don't get correction of the angulation so much, minimal correction of the angulation. Now, I was thinking of how to improve efficacy and durability of response. So I did one thing which Professor Irvin Goldstein was doing in America. We were doing it independently. I was shocking the spongy urethra. The reason why I was shocking it was because many of the erectile dysfunction patients complain of a soft glans penis. They always say that the erection is so bad, but also the glans penis, the head of the penis is soft. By shocking the spongy urethra, you can improve blood supply to the head of the penis. And therefore, this is the rationale for shocking the spongy urethra. Now, I was telling you that I toyed with the idea of augmenting the process by giving PDE5 inhibitor as adjunctive therapy. So I had two ways of giving it. One way was the chronic administration of a low-dose PDE5. But there were many patients that were non-compliant, especially in Asia, where the education level is not so high. So if you have that kind of patients who are non-compliant, what I did was I made them appear at the clinic earlier, and I either gave them oral dispersible type of Viagra, 50 milligrams, 1 hour before I start the treatment. Or if I didn't have 1 hour to play with, I gave them the new Spedra drug, 200 milligrams, 15 minutes prior to ESWT treatment, right? Now, this was my report of my patients. You can see that those who had 5 milligram daily dose of tadalafil in this series had a very good response rate, you see, to ESWT treatment, 79%. Now, this was the low-dose PDE5 that was created by Lilly of the USA. Now, this was the Spedra, is otherwise known as Avanafil, produced by Peyronie, an Italian company. And of course, if you had more time, then you can give the Viagra ODT, oral dispersible tablet, which also works a bit faster, but you need a longer time. If you want a quick response, you have to use Spedra 100, and the 100 is not good enough. You need 200 milligrams, sorry. The picture is the wrong picture. It should be the 200 milligram picture. Now, this technique of mine came to my mind because I thought, if you look at how the shockwave create a response here on my right, it stimulates endothelial nitric oxide synthase, increasing the amount of nitric oxide in the tissue. So to me, if you had more nitric oxide in the tissue, clearly that could impact on the response rate of the therapy. So I was augmenting the amount of nitric oxide in the tissue during the treatment, and that was the rationale behind this way of treating people. Now, because of my finding, together with Irvin Goldstein's finding of stem cell being activated in the cavernous cell tissue, I thought I'll inject PRP to activate it in some of my patients, and now I'm now using human-induced pluripotential stem cells that are grown on petri dish after 3 weeks growth. This is a new form of stem cells which Singapore is one of the key pioneering countries doing it. So we are now trying out this new form of human-induced, human stem cells actually, human-induced pluripotential stem cells. So the use of stem cells, you can use it injected during the treatment, which is, to me, will improve the. I haven't confirmed this, but I suspect in the series that will come out later, it should show a better response to ESWT treatment. Right now, my main experience is using it post low intensity shockwave therapy that failed. Now, in these patients that failed my ESWT therapy and I gave them stem cell therapy, I could salvage the failures. Low intensity shockwave therapy stimulates the creation of more progenitor cells, which repairs the faulty endothelial and cavernosal tissue. That's the essence of the whole thing. Higher levels of circulating progenitor cells are found at areas treated with low intensity shockwave therapy. This is the finding of Irving Goldstein. And I think this is apparently the reason why stem cells or its activator, platelet-rich plasma, when given together with ESWT, works better. And currently, we are trying out human-induced pluripotential stem cell lines derived from human dermal fibroblasts, blood or cord blood cells. Now, what about the future? Anything else ESWT can work? I suspect it will work for female sexual dysfunction. And we are now trying to create protocols to test this out. Final remarks. Who are the patients likely to benefit? Well, top on the list will be vasculogenic patients, the diabetics, the obese patients, the hypertension patients, the metabolic syndrome patients, chronic smokers. PDE5 responders would definitely respond to shockwave therapy. So these are the ones we will recommend. And PDE5 non-responders, well, these are the groups need to have at least a certain erectile response and a relatively short period of non-responsiveness. If they are for donkey years not responding, they are likely to have a poor response to ESWT. So if you want to select PDE5 non-responders, make sure these are those with a short duration of this problem, and those who are non-responders, they get a bit of response, not zero. Then you will have some good results. My take-home message for all of you in the audience: ESWT is a non-invasive method to improve and treat the erectile function mechanism. ESWT is able to take the place of oral medication in patients who previously responded to PDE5 inhibitors. Shockwave therapy is able to reverse PDE5 non-responders to become responders once again. And I believe I'm quite convinced that using PDE5 inhibitors daily during the treatment increases efficacy of the therapy. And so far, from my experience and from the world experience, most patients will improve from a standard 6 treatment protocol. The way you administer the protocol is not a big deal, whether you do daily, every other day, twice, 3 times a week, or 2 weekly for 3 weeks. But the 6-session therapy will work in the majority of patients. So with that, I hope you have learned something from today's webinar, and I invite any questions from the floor.
Hi, Professor Lim. So I think we learned quite a lot, and it was very informative, it was clear, and we enjoyed your session. We do have some questions waiting, so I will try to read them one by one. The first one is, how many patients have you done, and what is the success rate?
Now, the first series was about 242 patients. Now I've done about 700 patients, actually. And my success rate is still around 70 plus. More than 70% will work with ESWT. And if you ask my former trainee, who is now the guru of ESWT in India, he's done thousands of patients, thousands. You know, because India is so big, because he runs many centers throughout India. That's why they have got thousands of patients, and their success rate, I'm told by him, is also around this figure. So I think it's a good modality. You cannot, you can't lose. You know, if you choose this as a first line after oral therapy, I think today, if oral therapy fails, this is the second line therapy for ED.
Okay. The next question is, how do you determine when to stop PDE5 inhibitors following the protocol treatments, especially elderly patients who were somewhat responsive for PDE5 inhibitors before the treatment?
Now this, when to stop the PDE5 inhibitor therapy is a personal decision by the patient. You counsel the patient that once you have given you the treatment, you could stop it at that point in time. That's one way. Another way is that after finishing the treatment, carry on with the PDE5 chronic administration for a few months. And then if you feel everything is wonderful, then you can try taking it off and see whether it can carry on the same result without PDE5 assistance. And then there's another group, I would tell them to carry on ad infinitum. And these are the people with bad and multiple comorbidities. I mean, clearly the people with comorbidities, you know that they are the ones likely to have relapses. So these are the ones I would put them on a sustained continuation of PDE5 inhibitors. But now the next chapter in this PDE5 saga, this ESWT PDE5I saga would be to see those who are taken off immediately after the shockwave, those who are taken off a few months later, and those who are maintained in the long term, how many relapse. So we are too early for us to report this, but this will be the next type of research we should be doing. All right.
Noted on that. The next question is regarding prostatitis, about the protocol. Where do you apply the applicator? How many shocks? How many sessions?
Can you say the last bit again? How?
Yes, it's about patients with chronic prostatitis. How do you apply the applicator? How many shocks do you recommend, and how many sessions?
Actually, I actually showed the slide answering these questions. You give 2,400 shocks total, and you do it like you would for ED. Just do it 3 times a week, 2 times a week, until you reach the total number, 2,400 shocks per session, until you complete the 6 sessions. Now, the interesting thing about chronic pelvic pain syndrome, which I did not mention earlier, is that I've done it in women also. Now, in the treatment of chronic bladder pain in women, I run a very busy chronic bladder pain clinic in women. And I've used shockwave therapy, and it works in women. But in women, I must tell you that when you shoot in the area around the perineum of the woman, you're shooting into an air-filled vagina, and the shock waves are lost. So I have created a mole. When we put into the vagina the mole, then we shock wave. This mole must be able to transmit the shock waves into the pelvic floor. So this mole can be a water-filled, balloon-like, sausage-shaped mole, which can transmit shock wave into the pelvic floor region for female chronic pelvic pain syndrome patients. And it works very well in women then if you do this using this mode. So I would like to recommend the manufacturers of shockwave machines to encourage their doctors to apply shockwave in female urology in the women population. And that's also the reason why I suggested that we should be using it for female sexual dysfunction. It's another way of improving female sexual dysfunction if the pelvic floor has anything to do with the female sexual dysfunction, or if vascularity has anything to do with female sexual dysfunction, then by increasing vascularity, you should improve female sexual dysfunction. So I think I've answered your question. 2,400 shocks per session for chronic pelvic pain syndrome.
Okay, so thank you for the answer and for elaborating also for women's sexuality. The next question is regarding cardiovascular disease. If you have do you have the success rate for that, and does it matter what kind of cardiovascular disease?
Now, if you want to do assessment, I'm working with my cardiovascular surgeon, and I have a method. The color Doppler ultrasound to me is not good enough actually. So we have a hemodynamic evaluation for ED to pick up our vasculogenic ED patients. And we have found that the hemodynamic assessment, the evaluation that we do, is more accurate than color Doppler ultrasound. And it is less invasive than the color Doppler ultrasound. And it's very comfortable to do in the clinic. So for those of you who want to know this machine, I can ask my vascular surgeon, Dr. Shriram, to introduce you to how to use this machine. Yeah. We subject our patients to stringent evaluation with a hemodynamic evaluation. The machine, you see, the cardiovascular surgeon has got very sophisticated equipment to evaluate vascular dysfunction or inadequate insufficiency. And I use these super machines to confirm they are vasculogenic. And that's why I get very good results, because I pick up the perfect case actually to treat. And this hemodynamic machine also picks up corporal venous leakage patients, the venous leak erectile dysfunction, very well. And these are patients that will not work. The minute you have a patient diagnosed as veno-occlusive erectile dysfunction, reject him from shockwave therapy. It will not work. You're wasting your time. So get good evaluation before you do it, or you will get failures.
Okay, as we are past our time, I will allow one last question. And the question is, do you use the same applicator to treat Peyronie's disease, or you require a different applicator, or any modifications?
Now, in the original series, the company gave me different shock heads to treat different problems. But today, we have now changed to using the same shock head, and it seems to work equally well. So I don't think you need to keep on changing the heads. In the German machine, they use the same head also, and the German machine has got a dial that you can change the power of the shock wave. But now with the current machine, the Medispec machine, with the same shock head, I find it gives me the same results, whichever condition I'm treating. So I don't think that is a major consideration anymore.
Okay, so as this was the last questions, I would like to take this opportunity again to thank you, Professor Lim, for this exciting and very, very interesting presentation. I would also like to thank all of our guests, and I would like to invite you to follow us on our post and marketing publications for our next webinars. And we look forward to seeing you again very soon. Thank you and bye-bye.